and welcome to another episode of our program. Today it's an English version, and today we will be talking about altered anatomy. In fact, about sealing the altered anatomy. And my guest will be a doctor from Romania, and I can say my good friend Bogdan Moldoveanu. Let's have a talk about anatomy. Hello, Bogdan. How are you?
Hi, hello, Greg, and hello, everyone. Thanks for having me. It's really a pleasure to be in the show. I've watched a couple of episodes already, and I must say it's you're doing a fantastic job. So it's definitely an honor for me to be part of this show, and hopefully I'll be able to contribute to the great production that you and your team are making. So thanks for the invite, and let's hope that we'll have some fun.
Yes, and just coming to the subject, I have some questions prepared for you. So I will just straightforward ask you some questions. The first question will be, what do you think is more important, proper sealing or proper rinsing? And I understand that this question is a little bit tricky, but this program is a little bit tricky, so we are just asking these kind of questions. So please, can you respond to that?
Well, I guess it depends on who are you asking the questions to. If you're talking to someone who is completely focused on endodontics, he will most likely argue that rinsing is a big contributor to what long-term success is. Now, if you, let's say, widen your approach a bit, you will come to understand that you need to treat the tooth as a whole. So, just doing a fantastic endodontic treatment will never benefit the patient in the same manner as will be performing an adequate root canal treatment and an adequate restoration as well. So I don't think it's a question of which is more important. I would rather say, why not do them both? Why not make them both equally important? Because, there's a saying, a good endo and a bad resto is probably the same as a good resto and a bad endo. And how about a good endo and a good resto?
Well, I totally agree with you. I was just curious about your answer because, we are doing lots of endodontic treatment and we see from time to time bad endo. Well, not from time to time. Most of the time we see some problems with the endo. And despite of the problems with the endodontic treatment, and when we have the sealed anatomy, sealed restoration, properly done, then there is no problem in the response from the tooth. The patient is happy and he or she is saying, oh, nothing is happening. I don't feel anything, right? Okay. So talking about sealing, let's first talk about sealants because, sealants have been the most exciting subject lately. So today we are talking about non-standard cases and filling spaces that are often hard or reached by files. So which sealant is the best choice in such a cases, right? Is there any gold standard? What is your preparation for that?
you know Talking about let's say the commercial products that you now have, different sealers and different compositions of the material, I would go back to what Grossman said as early as 1958. He was saying back then that he's amazed of how many formulations have we come up with in order to seal this hole inside the tooth. He was talking about the root canals of the central incisors. And this was back then in 1958. And he also said that based on what he has studied, the root canal space is the cavity in the human body who has received the most materials through the ages. So it seems that we are always trying to, let's say, place something new inside without actually getting a clear understanding of why we are doing that. So I would try to answer your question by providing you with another question. what would you search in an ideal root canal material? What would you like it to do for you once you've placed it inside the root canal space? Because once you'll answer me that, I can further provide you with an opinion.
Okay, so you want me to answer this question. Well, okay. Well, let's say my approach, despite of what is happening on the market at the moment, where the BC sealers, or let's say hydraulic cements, are very popular right now, still, I'm just not saying that they are the only option, right? They are one of the options, but they are not the only option. So for me personally, as an endodontist, what I want to achieve with my endodontic treatment is as proper seal as possible with the obturation of lateral anatomies and lateral canals and everything what I can fill in. And in fact, I don't care if I will obturate it with the sealer or with the gutta percha. And we both know that when we have the isthmuses and the lateral anatomy, it's a science fiction that we think that we inject gutta percha in the lateral anatomy. Most of the time, it's just the sealer, right? So what I want is that sealer will not disappear from the canal. It will be properly visible on the X-ray. So most of these things are already been said by Grossman. So yeah, that the perfect sealer for me is it's not disappearing. It's as biocompatible as possible and seals everything what I already rinsed or cleared, right? So that's my answer.
Yeah, which obviously makes my job a lot easier, because now I can give you a straightforward answer to your question. You would want to use a zinc oxide eugenol sealer, and I'm going to tell you why. With the advent of epoxy resin sealers in the last years, I've been quite amazed to see how we use them with continuous wave condensation or heat carrier based techniques. Because when you're talking about sealing lateral anatomy, you're obviously talking about a technique which is using warm gutta percha. So it can be continuous wave, it can be multiple wave, it can be a carrier-based technique. Regardless, you're talking about you're talking about using a heat source in order to plastify the gutta percha and also to have some hydraulics in terms of the sealer. So you definitely want a sealer that can properly react from a chemical standpoint when heat is applied. And the best sealer, as knowledge provides us today, is a zinc oxide eugenol sealer, which gets very fluid when applying heat and has a good hydraulic property, opposite to what an epoxy resin sealer has, which we know by now. When you heat it, it doesn't, let's say, become easier from a hydraulic point of view. It actually becomes much more difficult to properly use it, because all the resin epoxy sealers, when they were first invented, we can go back to the AH26, let's say the precursor of AH plus. It was a sealer designed for lateral condensation because it was fairly easy to use, it was fairly easy to manage, and it was fairly, let's say, and it was an easy technique to teach everyone how to use it. You had to basically mix it in order to provide something which was very commonly known back then. We're talking about the paste, all the paste that we used prior to the sealers, and so people really enjoyed it, having a sealer which is like a paste. Compare it to zinc oxide eugenol sealer, and you will find the different material which is bulkier, which is heavier, and which is not liked by many of the general dentists, because if you have an extrusion with such a material, obviously the patient is going to have discomfort. And when you're doing any warm condensation technique, extrusion is a possibility, or rather a probability. So a patient who is calling you after the appointment telling you that, I came in, I didn't have any problems, and now I have this soreness, I cannot bite on the tooth. Well, if you don't explain things prior, you're going to have a difficult time explaining them afterwards. So people moved away from the sealer and they gravitated towards the epoxy resin sealer in order to do the proper continuous wave as they saw it as being proper. So you are wanting a warm condensation technique, and you would want a sealer which can seal lateral anatomy. And that is my answer, zinc oxide eugenol sealer.
Okay, I will not agree because also I can achieve same things. But okay, let's be honest. It's operator dependent, right? It's technique dependent. So, for example, for me, obturation with the I mean, I don't feel any difference in obturating with the epoxy or BC sealers. Well, I'm not using zinc oxide for years now, but of course, it's not wrong. It was working still, right? It was okay. But I mean, the thing is that you don't need the heat source for obturate lateral anatomy, for example, with the hydraulic cements like BC sealers. And there is a question from the audience. By the way, Piotr has joined us. Hi, Bogdan. Hi, Gregory. Hi, Peter.
Hi, Piotr.
Adrian is asking, what is our guest's opinion about BC sealers? So, what is your opinion about BC sealers or hydraulic cements, as they named by Josette?
I use them quite a lot, because I'm not very focused on sealing the lateral anatomy. This is a subject that we do not agree upon. I don't believe it's worthwhile sealing the lateral anatomy. In fact, if you want me to make overall, let's say, assumption about what is most important, just sticking to the root canal, so what we do inside the root canal, I can tell you that it's quite important what you remove. It can be necrotic tissue, it can be previously placed filling material. Then we are going to move forward to your irrigation protocol. And lastly, we have how are you going to fill it? So I would rather focus on those two aspects prior, and I would only look at choosing the filling material in the end. From my perspective, the right filling material is something that can be used easily. So you don't need a lot of gadgets, you don't need a fancy technique to use it, and it can reach a satisfactory level of sealing inside the main root canal, the root canal space which you've prepared, because we know since the 1980, with the beautiful images that we had back then with the transparent teeth injected with ink, so nothing fancy. You already knew back then the anatomy, and now you obviously have all the micro CT images that can better show you what truly is happening inside a tooth. You will never have an X-ray like that. So as long as we are not able to properly shape or disinfect the entire root canal anatomy, I would rather focus on what I can seal in terms of what I can shape. I can properly shape and disinfect the main root canal. So I'm going to stick with sealing properly the main root canal. And bioceramic sealers are definitely a great option. Right about now, I'm 50-50 in terms of choices. Probably in 50% of the cases I use continuous wave condensation. In 50% of the cases I use bioceramic sealers.
Okay. Well, in this, I totally agree that shaping and irrigation protocols are much more of an issue here. And of course, what you choose for the obturation. So just to make it clear, what material you choose for the obturation, it's a secondary option. The first option, I totally agree with you that cleaning and shaping, or rather shaping for cleaning or cleaning and shaping, right? It depends on which type of technique we use. But still, the material, yes, you're right. The choose of the material is not as important for the sealer. So I think we agree both about this. Yes?
Yep.
Okay. And we have another questions. What about, from Sebastian, what about the restorations after endo with zinc oxide and eugenol sealer is used?
Yeah, well, obviously, when you're using a zinc oxide eugenol sealer, you need to take heed of the changing your protocol in terms of doing a restoration. So after you completely fill the root canals, you obviously need to use a solvent in order to remove the sealer. I use eucalyptol for that. So basically flood the cavity with eucalyptol and then use micro applicator in order to try and remove all the sealer from the root from the cavity walls. Afterwards, I would always rinse with alcohol and then I sandblast the cavity. So it's a lot more difficult to remove it than it would be a resin-based sealer. I know when you're talking about resin-based, you just need to rinse with alcohol and everything is quite clean and looking very nice. When you're using zinc oxide eugenol sealer, yeah, you need to do a couple of extra steps. It doesn't take long. You have your sandblaster and your dental unit. You just need to use a little bit of alcohol, but you need to do the steps. Either if you don't do them, you're going to have a difficult time in getting proper adhesion. So getting back to the first question you addressed me, then you're going to fail in a step which is equally important as the good quality root canal treatment you just performed, and that is the restoration.
Okay, so another maybe controversial question, but we like controversial questions and we don't have to, discuss about things which are very obvious. So, puffs. I mean, we are looking at social media and lots of people are just amazed with the puffs and everything. If you don't have a puff, you don't have an endo, right? But is puff always a good syndrome? When should we avoid it and when it is right to make one?
Avoid it every time. There's no point in getting material outside of the root canal space. The material we use is called root canal sealant. It's not apical sealant. So I see no reason in getting a puff. It's just in order to satisfy your ego or to have ease of mind. When you have a blocked root canal, a ledge, a blockage in the apical portion you cannot manage, and then you do a continuous wave condensation and you compact the gutta percha and some sealer finds its way to the apical portion, then you're going to say, oh, great, this is fantastic. I've reached the apical portion. I'm going to have a great result. The truth is you're going to have a great result either way if you did proper disinfection. So managing to get a little amount of sealer outside of the root canal is, from a statistic point of view, of no benefit. And we have tons of studies on this. Getting the material outside of the root canal actually worsens the prognosis, especially when you're talking about zinc oxide eugenol sealers or resin-based sealers, because even though these are not toxic materials, because we are not using toxic materials on patients, but these are materials which impede healing, because healing, the process of healing, let's say, is quite complex, but let's break it down fairly easy. Once you have completed your root canal space and you have a lesion, you're going to have new cells coming there and differentiating themselves into osteoblasts. Now, in order for a cell to be able to differentiate, it needs to have a proper environment. If you have excess of material, that material will not allow that proper environment and will impede differentiation. So, if I have a puff with the material after I've performed good root canal treatment, an excellent root canal treatment, the best in the world, my healing will be slowed down by that puff. If I wouldn't have had the puff, I would probably see a good healing in 6 months. With a puff, I will see it in 1 year. And, I do like my healings to occur quickly. So no puffs from me.
Okay. So another question from Adrian. How about toxicity of the zinc oxide eugenol sealers? Or what is your observation with healing or big lesions with these kind of sealers?
There is no proper toxicity. So when we're talking about toxicity, it only involves the situations when you're going to push the material outside of the root canal, which, as I previously mentioned, this is something that you should never do. So obviously, you need to calibrate your technique in accordance to the materials and the instruments you're using. So if you are constantly having puffs or if you're constantly extruding materials out of the root canal, probably you should do something in regards to the way you're finishing your apical preparation. So the apical finishing, when you're doing the shaping, maybe there's something that needs improvement there. Other than that, it works as any sealer would. So I strongly believe that regardless of epoxy resin sealer or zinc oxygenol sealer, you will not have any difference in healing. When you're using bioceramics, I would say that the studies are promising. So you might have a material that can enhance healing. That doesn't mean it will improve healing, but it will hasten it. So using a bioceramic material, you'll probably see a quicker healing than you would an epoxy resin sealer, but that's about it. If you have a big lesion and you do a good job, it will heal regardless of what you've placed inside the root canal. You can even place a silver cone, I'm fairly sure it will heal. It's just a matter of doing proper shaping and cleaning. After that,
And with that, I totally agree that it doesn't matter what you put in. What matters the most is what you take out. That's the clue of endodontics. And if you master that, you're becoming a totally different endodontist. And your endo treatments looks totally different. So it's not about putting in, it's about taking out. I totally agree. Okay, let's discuss some specific cases, like, for example, apical inflammatory root resorptions. Well, do you use gutta-percha cone often? Because it doesn't seem to be a right choice. How do you manage in such cases?
yeah, this is a very good question. And I also think it's very important for everyone listening and looking at this right now to understand that apical root inflammatory resorption occurs at the very first moment you see a radiolucency on your x-ray. So when you have bone resorption, you immediately start having apical inflammatory root resorption. Now, the problem with apical inflammatory root resorption, it's not a process which is straightforward, or let's say it's in any way you cannot predict it in any way. So when you're talking about root inflammatory resorption, it can affect different portions of the root. But in most of the cases, you will definitely find that the apical constriction was affected to different degrees. Whenever you have an apex which is larger than an ISO 50 file, I would argue that from that point onward, trying to seal that apex with gutta-percha sealer is quite risky, due to the fact that you might have a huge extrusion of material, be it gutta-percha, be it sealer, and also due to the fact that we are now talking about a very irregular space, because apical inflammatory root resorption means an irregular resorption of the apical portion. So you're not going to have that apical preparation that you might have when treating a tooth which has suffered from a pulpitis. So it becomes very different to adapt the material in the apical portion. In order to have an adequate seal, I would argue that a bioceramic material in a putty consistency might be the right choice. So you can go for biodentin if you want. You can also use MTA if you've been accustomed to it. It works as great as biodentin or any other bioceramic material. Again, I cannot stress how important this is for me in my practice. Any material that you decide on using, you must be able to use it with ease. So you need to be able to do the procedure in a manner which is highly predictable. If you are having difficulties, if you are struggling with, let's say, MTA, and you prefer biodentin, that's great. You just need to know that the materials which you are using are similar and they produce the same results. And talking about sealing the altered anatomy in terms of apical inflammatory resorption, you can definitely go with either one. You'll get the same results. So choose the one that you can adequately place, because anytime you're going to place MTA and biodentin, you're mostly talking about one shot. Now, if you have the X-ray in your office, you can definitely take an immediate post-op X-ray. And if you're short, you can maybe remove the material and try again. But if you need to send the patient to an X-ray, let's say, clinic, because you do not have an X-ray in your office, then it's going to be a little bit difficult after 24 hours to remove the material, because it's going to be hard as cement. So there's no way of removing it. So if you close the tooth quite a long way from the apex, well, some issues might arise there in time. Not 100% certain that you'll have some problems, but obviously, if you can do a great job, always try to do a great job.
We have another question from the audience. Anna is asking, but this question is connected to the eugenol sealers. Do you observe an allergical cases connecting with eugenol? In Poland, we don't use that sealer, so I'm wondering, how about your experience?
I've never seen an allergic reaction. I don't know. Maybe there are some allergic reactions documented in the literature. I'm not aware of that, so I'm not very informed in this regard. I never seen one in my patients or in any of my colleague patients. In Romania, eugenol zinc sealers are not popular either, so I'm probably one of the few who are using them. They're very popular in Italy, where I did my master's degree, so I'm probably influenced by the Italian school of thought, and this is why I'm using it. But as I previously said, I see no difference in the series you're trying to use, as long as you clearly state your goals from the beginning and you know that you need that material to obtain that goal. And from a prognosis point of view, it brings you the same level of predictability.
Okay, I think that's a proper answer for that question. And there is another question from Michał. Which one do you prefer personally, MTA or biodentin? And maybe
MTA.
I would just add why.
MTA definitely. Why? Because I have much more experience in placing an MTA apical plug, so it's fairly easy for me to place it. So this brings me back to what I've already stated a couple of times. I can easily place it, and most of the times I need to do no, let's say, modifications afterwards. So it's pretty straightforward for me. It's rarely that I need to remove it because it's not properly placed. When I'm talking about properly placed MTA, I'm not just referring to working length, but also to good compactation of the material. Because as with any obturation, you do not want voids. Having voids in your filling material, regardless of the filling material, it can be endodontic filling material, it can be coronal filling material. You wouldn't want to do a coronal filling with voids. So it's the same for endodontic materials. You don't want fillings with voids. So with MTA, the issue is that if you do not compact it well enough, and when dentists are starting to do MTA apical plugs, most of the times they're quite afraid to not push the material past the apex, so they do not apply too much pressure on the hand pluggers. So you see MTA fillings with a lot of voids. So it happens to me from time to time. That's why I believe the X-ray in the dental office is quite useful, because I can easily remove it in the 15 minutes time since you've placed it, using serum, rinsing with serum, and using an ultrasonic tip in order to, let's say, vibrate the material. You can remove it fairly easy. And just to complete the answer, from a radiological point of view, MTA is definitely better. You can clearly see it on the X-ray. It's highly visible. With biodentin, not so much. So I wouldn't want to ask myself, is it at the apex or not? Is it well compacted or not? I want to be sure that it's up to working length and very well compacted. So MTA.
What can I say? Okay. Yeah, we were laughing in Poland that that there are some problems with the, let's say, visibility of one material over another. Yeah, they are both very good visible on the cone beam. Yeah, so on the cone beam you can see everything with no problem. So sometimes we are laughing that if you fail by yourself, you do the perforation by yourself, use a biodentin. But if you close the perforation of your enemy or somebody which you don't know, use MTA, right? So it's always visible. Yeah, but it's a joke. Well, both materials are great. With the biodentin, there are lots of improvements. So from the biomechanical and from the, let's say, chemistry point of view, my opinion, biodentin is much better and much more advanced than MTA. But of course, we cannot say that MTA is wrong and that choosing the MTA material is worse or the biodentin is better. They are, let's say, very similar materials, but on the other hand, there are some differences. Me personally, I prefer biodentin because of the handling, especially from the handling. So this is for me very, very easy and very comfortable. But of course, I'm also using MTA from time to time. So I agree with you that, again, it's not only the material, but it's also the operator-dependent protocol. So it's always like that, I think.
Yeah, and obviously, I think in terms of biodentin, what you said is completely true. So, taking you back 6 years ago, when biodentin wasn't on the market yet for any perforation, because you mentioned perforations, I would be using MTA. Now, MTA is a fairly good material, we know it, but there is an issue, and that is when we're talking about perforations, the washout. Because if you have a large perforation, you're going to have blood there. You're going to do a proper hemostasis once you've placed the material, but that doesn't mean that you will not have circulation there. So blood will constantly be passing through that area. So with MTA, I would say it's definitely not an ideal material to seal perforations due to the washout and also due to the convenience of placing it. It's tons more easier to work with biodentin when sealing a perforation. So biodentin is definitely the best material to be used. Also, we're talking about maybe dealing with teeth which are of aesthetic value. So using MTA, regardless if it's gray or white, it doesn't really matter. If you have a material with bismuth oxide as a radiopacifiant, you'll have a discolorated tooth. With biodentin, you don't have that. So I use at the moment, I only use MTA in the clinic for sealing the altered apical anatomy. So that means doing an apical plug. But when we're talking about perforations, pulp caping, pulpotomies, revascularization, regeneration, call it whatever you want, I'm using the biodentin, which I also believe it's a material which, from a chemical point of view, is, let's say, the next step. So it's the evolution of the MTA, and especially in perforations, because it does one thing so much better than MTA, which is it permits the periodontal ligament to attach to itself. And when you're talking about perforations, this is the most important aspect that you can focus on, obtaining reattachment of the PDL. And biodentin will surely help you with that. So any bioceramics for that matter, but with biodentin I have a lot of experience and I also read quite a lot about it, so I can tell you that biodentin works. With other materials maybe they work, but I don't have the knowledge to talk to you about them.
I just wanted to mention that and just to discuss this matter, because I know that you are using biodentin, you as a biodentin user, and you do it extensively in some cases. So I just wanted to put this stick inside just to motivate you to explain to our audience. Bogdan, thank you very much for this nice evening. It was a big pleasure for me to have you as a guest here. We didn't finish our discussion. We have lots of other questions for you, but today we are just running out of time. So I hope that will be a next time to meet each other online, because we are also meeting each other every time on big conferences around the world. So but still we will see each other. Are you going to Chicago AAE?
To Chicago, no, but I think we'll be able to meet each other at Ideas. No?
I think maybe we will see, because I'm just still thinking if should I stay or should I go. you know.
It's always a nice experience there.
Yeah,
You
it's
can-
always a nice experience, but we all have, all these calendars very, very full of beautiful experience all the time. So that's the problem. Bogdan, again, thank you very much for this nice evening, and hope to see you again.
It was my pleasure, Greg. Thank you again for the invitation. I hope everyone enjoyed themselves, and yeah, let's do it again.
Thank you. See ya.
Bye.